Good morning. My name is Pete Croft. I am an emergency medicine doctor up in Portland, Maine, where we just got pummeled with snow overnight, about a foot and a half to be exact. It's quite blustery here, but we're going to focus less on the weather and more on gallbladder ultrasound and the basics of gallbladder ultrasound this morning. So what do we know so far? So we know that we're good at detecting stones. This is compared to radiology performed ultrasounds of gallbladders. ER doctors, as well as ICU doctors and medicine physicians, have been shown to be quite facile at finding gallstones. We also know that ultrasound at the bedside will decrease length of stay. It will also decrease cost to the patient. This has applications not just in the emergency department, but in the ICU, where you don't have to send patients down to radiology, or on the medical floors as well, when you don't have to order tests and wait for the results to come. Certainly expedites care for patients. Lastly, this is a bit more controversial, but a recent article proposed the idea that not finding the common bile duct, which is one of the tenets of right upper quadrant ultrasound, may not always be necessary. And this is only in patients that have normal laboratory profiles. But as you'll see as you start to do these tests, the common bile duct can be extremely difficult to find in some patients. And when normal labs, normal findings otherwise, such as no fluid around the gallbladder, no Murphy's sign, no wall thickening, things that we'll discuss momentarily, all these things point to a normal exam and don't always need the common bile duct to be seen for that to be shown. So it's quite an interesting development. So first off, the gallbladder tends to hide. It hides under the ribs, it hides under the liver. It's tucked away into the fossa of the liver, and this can pose some problems in identifying it and finding it. As you'll see here, as you'll notice, this gallbladder is hidden right here at the bottom, just underneath the liver. As we'll do this test, as you take a peek at this figure on the left, you're going to actually start your exam in the middle of the patient, or as this is where I want you to start, and you're going to slide your probe laterally along this liver edge, looking for that spot where that gallbladder is hiding. So what do I mean by that? Take a peek here at the top of your screen. You'll see your probe, in this case the transabdominal probe, oriented facing upwards, so towards the head of the patient. Here's your corresponding clip at the bottom. Notice this black or anechoic structure right in the middle. This is your gallbladder. It looks rather oblong in this clip. As you move down, so there's the arrow, as you sweep down just underneath the ribs, you're kind of traveling along that liver edge, trying to find the best spot to appreciate the gallbladder. So when you do that, you get a picture like that. As you can see, you can imagine this probe is sliding along the costal margin of the ribs. The other thing I want you to incorporate into your ultrasound, not just that subcostal sweep where you start in the middle and slide laterally, but when you do that, have the patient take a big, deep breath and hold it. This does a couple things. This keeps the image still and takes away respiratory variation. It also carries the gallbladder inferior away from the ribs and gives you a nice, clear picture. I do this with every patient. So in a stepwise fashion, the way I do these exams is I do a subcostal sweep, which I just showed you, from medial to lateral, right along the rib margin. Then I just go right back to the center again. I have them take a deep breath and I hold it, and then I repeat that. This almost inevitably gives you a good picture of the gallbladder and really takes a lot of the thought out of it if you do it this way every single time. If you're still having problems, the last ditch effort is I roll the patient on their left side and put them on their flank and repeat the process. This will take that hopefully hanging gallbladder and bring it towards the middle away from the ribs. Rarely do I have to do that. if I have a cooperative patient, he'll take a nice big deep breath for me. So there are 5 parameters to the gallbladder ultrasound that we are looking for when we do these tests. The first of which is the size of the wall of the gallbladder, or how thick the wall is. What is a normal gallbladder wall? Give you a second to think about it. You want to be less than 3 millimeters. That's going to be a normal gallbladder wall thickness, is 3 or less. Here's a nice representative picture. Notice the gallbladder right in the middle of your screen here, the top right. Where do you measure it? Do you measure it on the top there, nearest to your probe, or do you measure it away, kind of posterior aspect of the gallbladder? Well, the answer is fairly clear. It's the anterior wall. Look at that posterior wall. There's no differentiation of the wall at all because of what's called posterior acoustic enhancement. So as the ultrasound beams come down and hit that fluid-filled gallbladder, which is full of fluid, it's black, it will hit that gallbladder and shoot very quickly across the gallbladder to the posterior aspect. When this occurs, the speed of the beams make it so that they reverberate at the posterior aspect of the gallbladder and create all this artifact and brightness. So you can't measure the gallbladder at the posterior wall. You always measure it from the anterior wall for accurate thickness. Again, notice the arrow pointing at that posterior acoustic enhancement. It's very bright there. You're not going to be able to get an accurate measurement, whereas at the top or anterior portion of the wall or gallbladder, you get an accurate measurement. As you'll see at the bottom left of the screen, 0.22 or 2.2 millimeters, very normal thickness. I usually use the zoom feature on the machine to give us an accurate measurement. Remember now, you're measuring extremely small sizes, so millimeter to 2 millimeters. If you think of that, a grain of sand or 2 grains of sand, if you can do anything to make these measurements more accurate, do so. One of this is a zoom method. When you look at the calipers on the left side, they become so close to one another, you sort of lose your accuracy. So I always zoom when I do these exams. So that's wall thickness. Second major feature is going to be stones. And as I mentioned before, we're pretty good at identifying stones in the gallbladder. They tend to shadow. They are dependent, so they fall and use gravity, so they're usually collecting at the bottom or posterior aspect of the gallbladder. They tend to be mobile, so as you roll patients, you'll actually see these gallstones roll. And you always have to be aware or be conscientious of stones getting stuck in the neck. So a complete right upper quadrant ultrasound entails that you get a full view of the gallbladder in a 3-dimensional way, so that fanning back and forth. And it's imperative that you get into the neck of the gallbladder to make sure there's nothing embedded and stuck in the neck. Here's a still image. Notice your gallbladder full of stones, shadowing all the way down. Video clip showing similar. Notice the bottom left of the gallbladder there. Again, gravity dependent stones. Notice how they're collecting at the bottom of the gallbladder. That top right portion of the gallbladder looks fairly spared from stones, but this is a gallbladder that's chock full of stones. And remember, this doesn't mean that they have cholecystitis, right? So people walk around with stones like this and gallbladders like this all the time without any symptoms. Here's a stone right in that neck. So notice how if you take just a still image at the beginning, here we are zooming in, right there, there's no stone. But as you fan across, you notice that stone becomes more apparent, shadowing all the way down in that bottom right, in this picture, in this bottom right corner. This is an alternative to stones. This is sludge or mud kind of stuck in the gallbladder. Notice the difference here is that there's no shadowing. So there's no calcification of the sludge, so it doesn't impede the ultrasound beams coming from your probe. So the ultrasound, actually, the sonographic waves actually pass through that sludge and go beyond it. You can see the kidney below it. If that was full of stones, right here, that kidney below it would be obscured because you'd have the shadowing of the stones. Thickness, stones. Next really important feature, 3 of the 5, is going to be fluid. So fluid can be circumferential, but interestingly enough, it can also be very loculated, so focal. Cholecystitis does not follow a script. A gallbladder will not be uniformly surrounded by fluid in a nice, pretty pattern. It's often ratty and ugly and infected, right? So fluid, as you'll see in a moment, can be kind of stuck on one side of the gallbladder. So just keep your eyes tuned to that when you're doing these scans. Notice here, here's your gallbladder. Notice that stripe of fluid right on the anterior portion of the gallbladder. Anechoic and black. Here's another measurement of the wall. You can see a thickened wall, 0.5 centimeters. You can also see fluid superior or lateral to that measurement up to the left. You can see that anechoic or black fluid surrounding the gallbladder. You can actually see fluid almost all the way around this gallbladder. Here's a great picture. So notice the sludge in the gallbladder, and then look at all that fluid around the gallbladder wall, especially in the top. It tends to be more dominant in the top here of the gallbladder. Another thing just to remember is that fluid around the gallbladder does not equal pathology either. So I mentioned stones, you can have those and be asymptomatic. Fluid as well, you can be asymptomatic from people with cirrhosis or HIV or protein deficient states will often have false, or not, the fluid's there, so it's not necessarily a false positive, but they will have fluid around their gallbladder for other reasons, not cholecystitis. So you got to bring into the clinical picture is very important here as well. So that's 3. The fourth one, again, I mentioned this earlier, is the common bile duct, which can be really tricky to find, especially when you're just starting off, and kind of can dissuade people from following and pursuing this type of ultrasound. However, I want to reiterate that getting quality ultrasounds of the gallbladder with good labs should give you a lot of reassurance that the patient does not have anything terrible going on. So, Mickey Mouse Club, kind of before my time, but why I'm showing you this is because you've heard of the Mickey Mouse sign. Notice the gallbladder in the upper right here portion feeds into that confluence here. So here's your portal vein. Make it blue for Venus. Mickey Mouse's left ear, if stage left, looking at you, is going to be your hepatic artery. And then there's your common bile duct on the right. Let me bring your attention to the association of the common bile duct and the portal vein. The common bile duct sits right on top of the portal vein. And that becomes important when identifying the common bile duct. Here's a color view. So notice the pulsatory hepatic artery right in the middle of the screen, that little bright red one pulsing back and forth. And just to the top left of that is going to be your common bile duct. Notice how it does not fill with blood here, and it's not pulsatile. Here's a couple still clips. Again, here's this association with the portal vein identified by the letter P there, and then the common bile duct sitting right on top. Notice how they run in parallel with one another. So the key and trick to finding it is often, your probe will often be oriented facing towards the patient's right shoulder. What this does is brings that portal vein in a long axis view, as you're seeing it here. And I always look just on top of the portal vein for a slightly thicker walled common bile duct. They talk about the common bile duct wall looking like railroad tracks or tram tracks. As you can see on the right zoomed in picture, you can see that the common bile duct wall is slightly thickened. That's an identifier for it. What's the normal size? Remember, the wall thickness was less than 3 millimeters. All you got to do here is just simply double it. And it's going to be less than 6 millimeters is going to be normal. You get about an extra millimeter per 10 years above the age of 60. Again, I don't expect you to remember all these things, but remember 6 millimeters or less for people that are 60 years old or less. If you're 80 years old, you can actually be up to 8 millimeters. And post-operative, so people that have had their gallbladder out, this measurement sort of goes out the door because these patients can have dilation up to a centimeter at least. Here's a patient with a large common bile duct. They also had signs of cholecystitis, so fluid around their gallbladder. But notice this duct is quite enlarged up to 0.8. This was a 40-year-old female. So that's your fourth. Lastly is your Murphy sign. What's a Murphy sign? A couple of things. We remember the clinical Murphy sign is having the patient take a deep breath and their inspiratory drive or movement stops or ceases with the deep breath when you're holding palpation in that right upper quadrant. With the gallbladder or the sonographic Murphy sign, what you're actually trying to do is compress the anterior wall of the gallbladder. So in those earlier clips when you're seeing the gallbladder, if you simply press your probe into the patient, you can actually see that wall deviate downwards and compress. That is equivocal to a sonographic Murphy sign. So if their pain worsens with that movement, then they would thus have the sonographic Murphy sign. So that's the fifth. So to review, wall thickness, boom, got that. Stones, we know we're really good at that. Third one is your fluid. So remember, fluid can be loculated or it can be circumferential. Remember that common bile duct runs parallel with the portal vein, parallel with the portal vein. Look right on top of the portal vein for your common bile duct. And remember that appearance of the common bile duct is rather thick walls. And then lastly is your sonographic Murphy sign, which is a bit discrete from the clinical Murphy sign. Just remember to push your probe into the patient right upper quadrant as you're visualizing the gallbladder. Those are your big five features of right upper quadrant ultrasound. So a few extra tidbits, a bit of a potpourri of ultrasound findings that you'll see here, some other more interesting cases. So again, gallbladder right in the middle. Notice that liver edge. Gallbladder always sits right on that liver edge. So that's where my eyes always track to. These little lines going across the gallbladder are normal variants. These are normal gallbladder folds. You'll see this all the time. This does not indicate pathology. Again, gallbladder sitting right in that crevice of the liver, anechoic. You see these little bright lines shooting down from the top of the gallbladder wall. If you didn't know what these were, you'd think that maybe they're stones, but then stones shouldn't stop. They should shadow all the way down. These look like little shimmering artifacts. What these are is something called, no, bear with me now, is Rokitansky-Askoff sinuses. Basically, it's cholesterol crystals that form in the gallbladder wall. It's something called adenomyomatosis. Again, normal variant, but you will see it as you start to do more gallbladder ultrasounds. Those little shimmering lights come from the top of the gallbladder wall in this case. Now, what the heck's going on here? So you see the liver at the top of your image, and you see where the gallbladder should be, right in that crevice or right in the crease of the liver edge. And then you just have a large area of black. Now, is this a rib? No. Rib would be up higher, right above the liver. So whatever is causing the shadow is located or localized just in that liver crease. This is actually a gallbladder that is full of stones, something called the Wes sign, or Wes. Wes actually stands for wall echo sign. So this gallbladder is full of stones, so much so that you can't even appreciate it. All you're appreciating is stones. I just taught at a course a couple weeks ago where one of the models had this. She was completely asymptomatic. She was 21 years old, and I've never seen it in a model before, but she had what's called a wall echo sign. It was right after she ate as well. So the gallbladder had already transmitted all of its fluid out into the bowels. It was left with just stones. This can be a fake out here. Notice your gallbladder is that oblong structure in the kind of the top right of your screen. You can see it feeding down, and it's that bright white structure right underneath it can often be called the gallbladder. That's actually your duodenum full of air. That's not stones. It's your duodenum full of air, but it can often be sitting right there where the gallbladder would be. So just be on the lookout for bright white structures. That's going to be more likely air-filled structures, or the intestine, in this case your duodenum. And then lastly, I think this is our last one, this is a fistula from the intestine to the gallbladder. You can actually see some air bubbles coming through into the gallbladder from the intestinal fistula. This is also duodenum, which, as I mentioned, has a very close affinity to the gallbladder in terms of anatomy, but this is a fistulization into the gallbladder. Pretty neat. So that's all I have. Thanks for listening in and bearing with us. I need to go do some shoveling now, but if you have any questions, shoot me an email. My email's not up there, but it is croftp@mmc.org, croftp@mmc.org, and I look forward to hearing from you, and good luck with your scanning.